Welcome back to Open My School, the Journal Club of. So today we are discussing an article that came in the New England Journal of Medicine, June 10, 2026. Hospital policy of Tranexamic acid to reduce transfusion in major non-cardiac surgery. That's the title of the article. So we know that tranexamic acid is a synthetic lysine analog that will prevent conversion of plasminogen to plasmin. The plasminogen is converted to plasmin that acts on the clot and produces thrombolysis. So what is the advantage? This blocks the conversion of plasminogen to plasmin, so it stabilizes the fibrin clot. That is the advantage. So it is already proven and useful in trauma, obstetrics, cardiac surgery, orthopedic surgery. But if it is implemented as a policy for all hospitals for non-cardiac surgery, what is efficacy and what is the safety? That is the question. So the study question is, does implementing a hospital policy of routine administration of tranexamic acid before major cardiac surgery, non-cardiac surgery reduces blood transfusion without increasing the thromboembolic complications? So, going to the study details, it is considered as a pragmatic, multicenter, cluster-randomized crossover study. What is meant by this? Pragmatic means it tests the effectiveness in routine clinical practice rather than in a research-based setting. So, it is a real life what is happening or what will happen, that is being tested. Multicenter, it is conducted across multiple hospitals. Cluster randomized. Here the hospitals are the clusters rather than individual patients were randomized. So hospitals were randomized. Crossover means one hospital initially gives a policy of giving tranexamic acid. Later it switches over to the routine policy. That is how it is done. So who are the participants? It was done in the Canadian hospitals. Adults undergoing major non-cardiac surgery included general surgery, vascular surgery, orthopedic surgery, gynec surgery, urology, so across multiple disciplines. So what is the intervention? Administer tranexamic acid before the incision. So the dose was, there is little flexibility. The 1 gram before skin incision and 1 more gram at the time of closure. In some hospitals it is given after 2 hours. Some places it is given IV infusion. So this is that is why it is called, it is depending upon the hospital policy administration, there is a flexibility was there. So dose according to the hospital protocol. It is combined with the usual practice, that is routine policy, that is without any tranexamic acid. What is the primary outcome? One was effectiveness, second was safety. Effectiveness is identified by the number of blood units that were consumed, and safety was the thromboembolic complications that occurred during the 90 days. That was the outcome. So let us go into the results. A total of 8,273 patients were enrolled in the study in 10 Canadian hospitals. 60% were oncological surgery, and it was found that in those who were receiving tranexamic acid, the blood transfusion was 7.4%. In the placebo group, it was 9.4%. The incidence of thromboembolic complications were same. In both groups, it was 2.1%. So that means the drug was effective, at the same time it is safe. So hospital-wide tranexamic acid policy reduced the need for blood transfusion, reduced the total blood units transfused. Benefits were observed across multiple surgical specialties. So conclusion, among patients undergoing major non-cardiac surgery, a hospital policy of administration of tranexamic acid resulted in lower incidence of red cell transfusion compared to placebo. And this was associated with no increase in the incidence of major thromboembolic complications. So safety is very important. Protein tranexamic acid did not significantly increase the DVT, pulmonary embolism, stroke, myocardial infarction. So overall, it was safe. What are the strengths of the study? It's a large trial, real-world experience, multiple surgical specialties, cluster crossover design, clinically meaningful outcome, and external validity is significant. Limitations were variations in the adherence, because being a hospital policy, some of the patients might not have received the drug. That is one of the major disadvantages. Second is, not all operations were of same risk for blood transfusion. So cannot determine benefit for individual patients. So what are the clinical implications? As I have mentioned, just what the good external validity can be applied to general situation. So hospital should consider routine perioperative tranexamic acid policy. Just what potential benefit of your transfusions, reduce blood bank utilization, lower healthcare costs, and improve patient safety. So if you compare with the previous studies, this study extends evidence across major non-cardiac surgery. Earlier studies like CRASH, Women Trial, POISE, etc. showed efficacy in selected settings. Here it is a wide variety of cases just found to be effective. So what are the practice pearls? It may be considered that tranexamic acid is given before surgical incision. Most useful when bleeding risk is significant. Avoid when there is significant contraindications are there. It is low cost, easy to administer, and a large population benefit is there. So take home message, the hospital policy of usage of tranexamic acid may be tried, and remember, blood transfusion is decreased.